Good evening and a very warm welcome to this evening's NB Medical Clinic, which is a lovely collaboration between NB Medical and Cancer Research UK this evening. It is so fantastic to see so many people joining us. I haven't done a clinic for a little while, so I'd forgotten how popular they can be, and it's fab to see the delegate numbers creeping up as we get started this evening. So a huge warm welcome to everybody that is joining us. By way of introduction, let's just get those out of the way. My name is Kate Digby. I am a GP partner in the leafy suburbs of the Cotswolds in Cirencester. I'm a trainer in my practice, and I'm clinical director for our local PCN in Cirencester. And the rest of my week I spend teaching on the VTS scheme as a programme director, and of course writing and presenting for NB Medical. So whilst I have presented on lots of different courses recently, I haven't done a clinic for a while, so it's great to be with you this evening, especially doing something which I think is super important and super useful for primary care. You will be very pleased to know it's not just me online this evening. So if you have any technical issues with the platform, please just drop us a chat or drop us a line in the chat box. And Glenn is waiting in the wings to help you with any IT issues. And my fabulous co-presenter this evening is Nick. So let's pass to Nick so he can introduce himself. Evening, Nick.
Good evening, Kate. Good evening, everybody. Yes, fantastic to be here and lovely to see so many people joining as well. Thank you for giving up your evening to be with us. I am a salary GP in central Oxford, and as many of you I'm sure are on the call, I'm a bit of a portfolio GP these days. So alongside the salary role I of course work for NB Medical, the highlight of our week. I'm sure you agree, Kate. And I work as a GP cardiologist in Oxford, which is a great role. So nice to sort of mix those different specialties. And then I work through the university here, undertaking some research in primary care, which is largely around cardiovascular disease, but I've done some interesting things around diagnostic tests from primary care for identifying cancer and things as well. So yeah, I think we've got a great evening lined up ahead. I'm sure you are all familiar with the NB program and approach, but just a reminder that while Kate is running you through the sort of presentation, I'll be in the background trying to answer questions that come in. I think that is one of the real joys of this online format, that you can ask questions as Kate's going through. And not only are they fantastic in terms of sort of thinking about some of the salient points that Kate might be talking about, I think they're really nice as an opportunity to share learning experiences that you might have from your own practice, resources, and we will seek to answer those as we go through, but we will also then come together at several points through the presentation, have a bit of a discussion around any main learning points that are coming through. So I will be rearing my head as the evening goes to break up the talks a little bit and reflect on some of those things. So do let me know where you are joining from, what your role is, what you're interested in cancer. I'm sure there may be people out there who have a special interest in cancer, for example. Do let us know that. And yes, do interact with me as the evening goes, because it will really make it more enjoyable for all of us. Kate, I'm looking forward to hearing what you have to say, so I will pass back over to you.
Thank you very much indeed, Nick. Yes, indeed. We will get back to Nick very soon. Please do let him know where you are and what you're up to. So this evening we are talking about managing uncertainty in primary care, the bread and butter of being a GP, I think. So what we're going to cover in the next hour is really just have a little bit of a reflection on how managing uncertainty is certainly one of the big challenges in primary care. And I spend an awful lot of time talking to trainees as they go through the VTS schemes about how to cope with uncertainty when you are managing patients. It's certainly one of the big challenges that they experience. So we'll have a little think about that and how we can perhaps mitigate some of the risk that comes with uncertainty. And think a little bit more deeply about safety netting in terms of what it is, but more about how to do it and how to do it effectively, because there are some simple changes that we could probably all make to make our safety netting a little bit more effective. And we now have some new tools available to us in the form of electronic safety netting tools. So we'll just touch on those as well. And then, as Nick says, he is waiting in the wings to answer any queries. So please, if you do have any thoughts or questions as I'm going through the slides, drop a note to Nick and let him have a think about it for you. Then he can come back and reflect those learning points when we pass to him for comments. And if you haven't found it already, there is a resource tab at the bottom of your screen, and we have uploaded an awful lot of Cancer Research UK resources all around sort of managing uncertainty, safety netting, e-safety netting tools. There are reams and reams of links down there, so please do have a look for those. They're takeaways really for you to have a look at in your own time. So let's have a little think about cancer diagnosis, just as by way of introduction. And primary care and GPs especially play a pivotal role when it comes to making a timely diagnosis of cancer. Now, we know that earlier diagnosis is strongly linked to improved survival. That's pretty much the case across the board for all types of cancers. And while survival has doubled in the last 50 years in the UK, there are still some significant differences that remain, and we are still lagging behind our peers in many other European countries that have similar health systems. Now, looking at this infographic here, you can see that the majority of referrals still come via primary care, whether that's in an urgent or a 2-week wait referral, or indeed just through a routine sort of something's not right type referral from primary care. And you can see also that when patients are referred through this managed route via their GP, the chances are their stage at diagnosis will be sooner than if they're referred an emergency. And it's worth noting that still almost a fifth of cancer diagnoses are still made after patients have been referred via that emergency route, when we know outcomes are often not so favourable. So that sort of it encourages us or incentivizes us to try and refer early in order to catch these diagnoses at an earlier stage. But of course, it's really tricky, isn't it, to pick up these patients that may have cancer. Of course, it's very easy if patients present with a breast lump, or indeed you have a postmenopausal lady who has a vaginal bleed. At that point, you automatically think about the possible diagnosis of cancer. But you and I both know that patients with cancer often present with vague and undifferentiated symptoms. And that is especially the case when their cancers are sort of in that earliest stage. Now, we also know that these vague and undifferentiated symptoms that patients very often come to see us with in primary care, when you look at these patients, the likelihood, the likelihood that this could be an underlying cancer diagnosis is very low. So we're stuck in this tricky position, this sort of rock and a hard place position, where we really want to try and avoid missing a diagnosis of cancer. Yet at the same time, we feel the need to protect our patients from unnecessarily referring them or unnecessarily investigating them, just in case this could be a nasty. Now, that said, there was a very interesting cohort study published in the BJGP. It's going back a few years now, back in 2020. And in this cohort study, they looked across 5 years of data. And they were looking at the association of a practice's use of the urgent referral routes with subsequent cancer stage diagnoses and mortality for the patients registered to that practice. And this was a UK-based study. It looked at 1.4 million cancer patients in England. And it's really interesting to note that within this study, what they found was that there was an association between practices with a high referral rate and a lower mortality rate for all cancers, including colorectal cancer, lung cancer, breast and prostate cancer. And there were significant reductions found in late-stage cancers from these practices where practice referral rates were much higher. So the conclusion from this cohort study was that the higher practice use of suspected cancer referrals was strongly associated with fewer late-stage diagnoses and lower mortality. And this really almost gives us permission to be referring patients when we're not sure what's going on, when we're a little bit concerned there might be something nasty underlying symptoms. Actually, don't be afraid to make that referral. We have now got evidence that making those referrals or referring more frequently actually can lead to better outcomes for patients who then get diagnosed with cancer. So just thinking a little bit more about vague symptoms, I just wonder what you think about this poll question. And this is really just to gauge the mood of the room, so to speak. What proportion of people diagnosed with cancer do you think initially present with vague symptoms? And when I'm talking about vague symptoms, I'm talking about a little bit of weight loss, some unexplained pain, perhaps tiredness, things that are really commonly seen in primary care, and probably more often than not are down to something completely unrelated to cancer. So what percentage of patients do you think present like this when they get diagnosed with cancer? Okay, that's great. That's practically everybody with their answers in. Thank you very much. Let's have a look. Oh, look. Well, it's almost a 4-horse race, isn't it? And that's almost very beautifully a quarter for each. So as it stands, actually the 30% have edged the win. But actually, I'll tell you now in a second, it's actually a little bit higher than that. Just thinking for a minute about our current referral guidelines. And if you work in England, we're obviously talking about the NG12 guidelines. If we work in Scotland, then we're talking about the Scottish referral guidelines. And if you're working in Wales and Northern Ireland, then generally speaking, you'll have your own guidelines, or indeed you will refer back to NICE or the SRG. And both of those sets of guidelines, when you think about what constitutes symptoms that would require an urgent suspected cancer referral, they really all sort of hinge around red flag symptoms or alarm symptoms that should trigger referral. But just thinking about that poll, it's actually more than 50% of patients initially present with non-specific symptoms. So we can't really, it's not necessarily in our favour to just rely on our current referral guidelines and just look for those alarm symptoms that might get you thinking about cancer. We actually do need to think about these low risk but not no risk symptoms that more than half of patients may present with initially. What can we do in primary care? So, of course, we may have some investigations that can help us. We are able to access some investigations from primary care, but depending on where you work and your local setup, those tests might be quite limited. And so if you can't further investigate safely within primary care, again, that's another reason to think about referral. The other risk of doing these tests in primary care is that actually if tests come back and they're negative, there is that false negative reassurance that comes with doing some initial investigations and finding they're all normal. And that false reassurance isn't just for the clinician, but it's for the patient as well. So if you reassure someone that their tests are all normal and it's unlikely to be something nasty, that may well reduce that patient's incentive to come back for follow-up because the doctor's already told them there's nothing to worry about. It may reduce their need for review, personal or perception of need for review. And of course, from a clinician point of view, you get reassurance that there's nothing abnormal objectively to find, and perhaps you don't think any further about it. So this is where safety netting really starts to play a part. And safety netting can be thought of as one of our diagnostic tools that we can keep in our sort of our armory of things that we can do when patients present to us and we're not sure what's going on. And effective safety netting has been shown to help manage patients who have these non-specific symptoms. It's especially useful to use when you don't know what's going on or when you haven't formed a definitive diagnosis of what might be causing the patient's symptoms. It's also very useful to use when you don't want to over-test, so you're trying to protect the patient from over-investigation, but you don't want to over-reassure that patient either, so you do want to make sure they come back for that follow-up. And it certainly does help to manage this diagnostic uncertainty, which we all have to shoulder one way or another when working in primary care. If you look for a definition of safety netting, then it can be defined as a management strategy that ensures patients are monitored throughout their diagnostic process until their symptoms are either explained or resolved. And it comes in a variety of different formats these days. So yes, you can bring people back for a timed review and physically see them again to see if things have changed. You can follow them up with a phone call or a text message, even send them an email if you wanted. And now, of course, we also have safety or e-safety netting tools, and I'll talk a little bit about those in a second. There are certain groups of patients who may experience poorer health outcomes and actually may benefit from sort of more active or more targeted safety netting. When I'm thinking about which groups these are, well, certainly there's those with the non-specific symptoms, because we know just from looking at the data that patients presenting with vague symptoms are more likely to experience multiple consultations before referral. And we're talking about 3, 4, 5 different contacts before that referral is made. And there are some cancers where that is especially the case. Those cancers include sarcoma, bone cancer, upper GI cancers, and brain cancers as well. And things like pancreatic cancer, which we know is incredibly difficult to pick up at that earlier stage of diagnosis, is one of those cancers where patients come back time and time again. There's also another group of patients, and those are the patients who are diagnosed or given medication for a long-term condition that might explain their symptoms. So examples here may be a woman presenting with recurrent UTIs who gets given prophylactic antibiotics or perhaps even some vaginal estrogen to manage her symptoms when in fact the underlying cause is bladder cancer. Or perhaps the gentleman with COPD who's having recurrent exacerbations who actually has an underlying lung cancer instead. You've got those who are infrequent attenders or people who are less likely to come back if their problem persists, and that's particularly seen in middle-aged and older people. And then you've got people who are less likely to engage with referrals or do some testing if you ask them to do so, or follow up on investigations. And we see that especially with men, with younger patients, or those who are coming from more socio-deprived areas. They're just less likely to follow instruction. For example, return a fit test that you've asked them to complete. So there's a couple of clear stages that sort of factors into when we're thinking about how to safety net. If we just spend a few moments thinking about that before we move on, and there's some very clear principles which we can try to implement and follow when we're doing our safety netting. The first can be sort of lumped together in clear communications. So give patients clear and very specific advice. So when, how, and why they should come back for review, or how they should seek help if their symptoms don't go away. What sort of timescale you're expecting their symptoms to resolve by. So when to come back if their symptoms have persisted beyond X number of weeks, for example. And then how to get back into the system. Do they need to complete a new triage form? Do they need to pick up the phone and speak to reception? Will you be sending them a text message to see how things are going? And let's make sure we try and use patient-friendly language, because we know it's very easy to use medical jargon, but patients often don't understand what we're talking about. So using simple patient-friendly language, making sure patients have understood us and are able to sort of reiterate what we've said so that you know they're going to take away the right message. And of course, when it's appropriate, using accessible or translated information. And there are really good sources for that now if you have a look in the resources tab. And if you can, provide them with written information to back up what you might have told them verbally. So this is really just to reinforce that two-way communication. If you can access leaflets or written summaries of the advice you've given, that's really helpful for patients. This shared safety net action plan picture that you can see on this slide, that came from a study conducted a few years back. And actually, they're very useful. They're sort of A4 pages. You can tick the boxes. You can write all over it. you can give patients a written information plan. At least they've got something to refer back to if they can't quite remember what the doctor said. The second thing in terms of principles is to remember that this is a shared part of the consultation, and we are actually using quite an active process here to sort of reinforce the information that we are giving. So confirming understanding, I've already talked about. Ask the patient to repeat what you've said. Encourage them to ask questions, because quite often patients feel they can't ask for clarification. So make sure you've given them permission to do so. Address any concerns that they may have, and you've probably, if you've been doing your consultation style correctly, you might well have already got their ideas, concerns, and expectations. But let's go back and check that they haven't got any new concerns or expectations regarding their symptoms or the investigations that you're sending them off with. And make sure that they have agreed to the steps that you're going to follow next in terms of follow-up actions and how to access you again should they need it. Now, whilst that all feels quite obvious and something that we would quite often do, let's remember when we are thinking about a consultation, often, we tend to safety net at the end of that consultation. It's as you're wrapping things up with the patient that you'll start to drop in this is what I'd like you to do next. This is what I'd like you to do if things aren't going the way we expect them to go. And this is what I'm hoping you'll do, and how you can get back in the system. And of course, when it comes, as we're wrapping up at the end, it probably, that sort of underlying non-verbal bit of the communication is that we don't necessarily want them to ask loads of questions. We're not opening the door for them to have a whole brand new consultation about the plan. So we just need to bear that in mind. Be mindful that we don't want to be dismissive when giving safety net information. Ensure we give that patient the opportunity to clarify what we're saying. And then, of course, we've got documentation. So making sure we've written down in the notes what advice we have given, making sure it's nice and clear and easy to understand in the notes, because, of course, patients now can read their notes. So if they're going to go back to your consultation when they get home to show their partner or their spouse what was said, then this might be how they get their safety netting information in written form. So just make sure it's nice and clear in the notes. And try and code things where you can. Read codes are really helpful to use. They are a form of sort of audit and tracking of that information that's been shared and the diagnostic tests that have been done. And this is potentially where the e-safety netting tools will come into their own. So e-safety netting tools take a lot of different forms. They may be templates which are built into your clinical system, allowing you to set up alerts and reminders so that follow-up actions are completed. They may automatically read code for you as you go along, so that those codes are in there for audit purposes, so that people can be searched up, looking for those specific codes to make sure that they've been followed up appropriately. They may be a form that you can send admin tasks and then use pre-populated referral forms. That's incredibly useful these days. And it might be that you can generate that safety netting information in written form or email, text message type form to send out to patients using one of these e-safety netting tools. Some of them even have tracking dashboards so that you can keep tabs on what has happened to patients. So just a quick poll question for you before we sort of finish up this last section. Do you regularly use an electronic safety netting tool in your day-to-day practice? If it's a yes, then great. If it's no, then I just wonder whether it's because you don't have access to one, you don't because you haven't started to use one, but you know it's there, or maybe it's just that you're not sure if you've got anything available to you or not. Just out of interest, I wonder how you currently practice. Okay, let's have a little look, see what people are currently doing. Okay, so 13% of people have said yes, that's great. But it's really interesting that actually the majority of people are not currently using e-safety netting tools. And that might be for a variety of different reasons. So perhaps this is worth just thinking about a little bit more. There are lots of good reasons to be using e-safety netting tools. Some of them I've mentioned already, but actually it is a great way of tracking patients and following them up in case if they may be at risk of cancer, perhaps they have got those vague symptoms. So that, that's a reason to start thinking about what tools may be available to you. Some of these tools are integrated into our electronic records, and some are provided by separate software. So it depends a little bit on which system you're using. But EMIS and System 1 have got some safety netting software already built in. Ardens is used quite widely, and they've got templates which can be very useful when it comes to this. So it's just worth a little bit of research to see what you've got available to you. And if you are part of that majority of people that aren't currently using e-safety netting tools, and you feel that this is an area that you could perhaps do a bit of QI work on, then these are just some ideas to get you started. So as with any QI work, let's work out first what is available in your practice and what the current use rate is. And then, of course, have a look and see what those available tools are and how they might be able to be better used in order to provide more safety netting information and support for both clinicians and patients. It's always worth checking user acceptability, so make sure they're easy to use. We know we don't like extra clicks if they're clunky add-ons, so just have a bit of an experiment. And then if you found something that actually might dramatically improve your use of an e-safety netting tool, then get some staff training involved. Let's roll it out to the practice and see whether or not you can change behaviours that way. So before we move on to Derek, I am just going to pause there, and I think we'll pass to Nick and say, Nick, any reflections on that bit before we move on to our next patient?
Thanks, Kate. Yes, there's some interest, I think, just to go back to the start, because people were sort of reflecting on the first thing we were talking about around the fact that the likelihood of people who have vague symptoms having cancer is low. So, obviously we see lots and lots of people for all sorts of different reasons in primary care, and the proportion who are going to turn out to have cancer is relatively low. But the flip side of that is that of the patients who actually do have underlying cancer, a relatively high proportion may present with vague symptoms. And that's the sort of quandary we're in here. I think that ties into an important point someone was asking around, when are we talking about safety netting here? And I think obviously you're talking about it particularly through the lens of people presenting with those vague symptoms, Kate, but it can come in at different time points kind of the referral pathway. So, for example, we have safety net practices around giving patients fit tests now to make sure that they are followed up, or around 2-week wait referrals to make sure that those are enacted on in a timely manner as well. So I don't think safety netting has to be specific to managing uncertainty, although that's where a lot of the literature was originally developed from. Most of the literature around safety netting has also been done through in-person consultations. I think it's really interesting thinking about the move towards more phone and remote consultations. There's relatively few studies that have looked at that, but there is one coming out in the BJGP soon, which shows that the sort of type of verbal communication around safety netting that's done over the phone seems to be quite similar to what's done in in-person consultations. But as you can imagine, written information is quite infrequently given. It was a very low proportion of people who had a phone assessment who were given a written safety plan. And there is actually quite, reasonably quality evidence that a written safety plan is particularly helpful and does make a difference in terms of patients coming back and retaining and remembering that information we're trying to provide them. So that's something else to think about. I think the last point to make is, obviously we're thinking about direct communication with patients, but there may be situations where safety planning is important to involve other people around that individual. For example, this is commonly seen in children, where we might need to give safety net advice to parents. But I thought it's also interesting in older people that sometimes safety netting to family members or to carers can be a really important thing as well. So thinking about the wider support network and making sure that other people are involved in the care where appropriate can be a good thing too. There's lots of questions coming through about about safety net tools and things specifically. So I'm going to go back to those, Kate. But yeah, it's great. Lots of questions. Thank you.
Brilliant. Thank you, Nick. Thank you, everyone, for your questions. I would just flag, if you look in the resource tab, there is a really good cancer research summary of available e-safety netting tools in various clinical systems. So well worth having a little look at that link, because you might well find some answers to your questions via the resource tab. Okay, let's move on and let's just think about some clinical scenarios now. And Derek is based upon a patient who I was involved in the care of a few years back. So name has been changed, obviously, to protect Derek's identity, but the clinical case remains the same. So Derek was a 78-year-old chap. He came to see me initially with some shoulder pain, and this was in around March time. So he gave a history of sort of a gradual onset of pain in his shoulder, been there sort of since Christmas. He hadn't had any history of falls. He hadn't had any history of trauma. It was there all the time, but he'd been taking sort of PRN, ibuprofen, and that had helped a bit. Paracetamol had helped a bit. Hot water bottle was a bit helpful as well. And there really wasn't anything else in his history to go on. So he didn't have any other symptoms. He was a non-smoker. To examine him, he had a bit of a limitation in the movement of his shoulder. There wasn't any erythema. There wasn't any tenderness. I thought, well, it could be is this early onset frozen shoulder, although it wasn't massively painful. I thought, either way, I thought this is probably musculoskeletal. So gave him some advice. Gave him, advice about topical NSAIDs rather than ibuprofen, given his age, suggested a bit of PRN cocodamol, and asked him to come back if things were no better. So indeed, he did. He came back the following month and he said, well, yeah, thanks, doc, but still got the same sort of problems. He didn't think that my magical Voltarol gel nor PRN cocodamol had made much difference to his symptoms. So at this stage, I thought, fine, let's get a bit of physio involved and let's get them to do a bit of a biomechanical workup of your shoulder. Gave him some shoulder exercise to keep him going whilst he was waiting to see the physio, suggested he come back if that didn't solve the problem. So just a poll question before I go on to tell you the rest of the story. What, if anything, and you can select all of these or any of these if you wish, would you have thought about doing anything else at this stage with Derek and his wonky shoulder that he'd had for a few months at this stage? So asked Derek to return after his physio if his symptoms hadn't resolved. Just put in that 1 month follow-up appointments, and this is on the basis that you have magical appointments available to book into. Would you at this stage refer him for some imaging? And at this stage, would you have thought about an urgent chest x-ray? Would you have broadened your diagnostic net and started to ask him about any other symptoms? What do you think you might have done in this case? Right, let's have a little look, see what other people would have done. So half of people would have asked him to come back after his course of physio. Some would have put him in for a 1 month follow-up. About a third would have thought about an x-ray, and 2/3 thinking about other symptoms. So it's interesting. So this was, I'd seen him sort of March, April time. June, he came back and the pain was no better. In fact, he thought the pain had got a little bit worse, and clearly physio hadn't really done him any good at all. Now we started to think a little bit more about other symptoms that may be going on. And he talked about being tired, but of course he was having real problems with sleep, because when he lay on that shoulder, it woke him up because it was sore. To examine him again, he hadn't got more of a frozen shoulder. In fact, the examination was unchanged. And he was at this stage, seeing one of my colleagues that does joint injections. So in fairness, because this all still felt quite musculoskeletal, he was given a steroid injection into that shoulder. Actually, that provided him with some relief, which was great. But unfortunately, then he was back again in the October when his pain was the same. And at this stage, he'd had an episode of hemoptysis, which is when the chest x-ray was done. And unfortunately, the apical cancer was diagnosed. And that felt really frustrating. I think as a practice, we felt this was quite a frustrating, when we reflected on the case, there'd been at least 6 months between that first presentation and when his diagnosis had been made. He'd come in to see doctors on various different occasions and had been referred, of course, to physio, and things had been done on each occasion. But we wondered whether we could have done things differently to have a better outcome. And of course, if you work in England, then you will have noticed that we've had all these new posters arrive at our surgeries, thinking about Jess's rule, which came into force in September 2025. But Jess's rule isn't new, of course. When I did my medical GP training 15 plus years ago, we talked about the 3 strikes rule then, and I have spoken to GP trainees about the 3 strikes rule ever since I've been a TPD, thinking, if the patient comes in to see you or any of your colleagues with the same problem for 3 times or more, do something different, because there is, clearly we haven't got to the bottom of that problem. So Jess's rule is just a very colourful and, it's a nice personal way of reminding us that if a patient presents 3 times with the same or escalating symptoms, we should be going back over that history and seeking a second opinion. Now, that might be a second opinion from someone else in the practice. It might also these days be advice and guidance to a specialist or some other investigations, or indeed, just doing something else rather than just keeping these patients under constant review. And when you think about pathways, and I've talked about NG12 and the Scottish referral guideline pathway for suspected cancer, they do have a section in both of them talking about those non-specific symptoms. So in NG12, they class non-specific symptoms as unexplained weight loss, appetite loss, or indeed the presentation with the DVT. The Scottish guidelines are slightly more broad. They talk about unexplained weight or appetite loss, unexplained fatigue, nausea, malaise or bloating that lasts for 4 weeks or longer, unexplained or progressive pain for 4 weeks or longer, and that might be where Derek would have been picked up a little bit sooner, and of course that GP gut feeling of cancer diagnosis. And if you do have patients that fits one of those sort of criteria for sort of unexplained symptoms that are persisting and you just can't get a handle on them, at that stage, think about an urgent investigation. Think about whether there is an urgent suspected cancer pathway you can refer down. Now, non-specific pathways have got different names, not just in different nations, but in different regions as well. So in England, we spend quite a lot of time thinking about NSS pathways. In Scotland, they go through the rapid cancer diagnostic services. In Wales, it's rapid diagnosis clinics. In Northern Ireland, rapid diagnosis centres. But they do have other acronyms as well. Locally to me, we've got the CUP pathway, the cancer of unknown primary ? Pathway, or we've just got the sort of vague symptoms pathway. So it's worth just knowing what is available in your area. And across the UK, this GP gut feeling of cancer diagnosis is, generally speaking, a valid reason to refer, because GP clinical suspicion of underlying carcinoma has been shown to be a very strong predictor of cancer. So in some areas, your non-specific pathway might just send people straight to a rapid diagnostic centre, and these have been set up variably around the UK as a one-stop diagnostic shop, trying to speed up cancer diagnosis by offering quicker access to multidisciplinary diagnostic testing. So non-specific pathways in general have been rolled out now over the last sort of 5 to 10 years, and we've now got some quite good evaluations and studies being shown to see how beneficial they have been. It's great to see that these non-specific pathways have got a higher conversion rate than many site-specific pathways. So a higher conversion rate means that those patients who have been referred down one of these pathways, query carcinoma, has then been diagnosed with a cancer. So, that GP clinical suspicion, that helps us, that reinforces the fact that we are pretty good at picking these up and using our so-called spidey sense. So The most commonly diagnosed cancers to go through a non-specific pathway include upper GI, lung, colorectal, and hematological cancers. And there's also a relatively high proportion of non-cancer but serious diagnoses made as well. So whilst that's a co-diagnosis, or whilst that's an alternative diagnosis, still very helpful to pick them up at a quicker basis. Excuse me. The other thing that's really, from a qualitative point of view, important to note is that both patient experience and staff experience of using these pathways has been pretty consistently good. So they are well received by everyone involved. So thinking about non-specific symptoms for a second, we've got active safety netting, and I've talked quite a lot already about active safety netting to help share diagnostic uncertainty. It's super helpful, especially when patients present with vague symptoms. It's really important, especially for people like Derek, to think about that time frame for symptom resolution and, those red flag symptoms that might trigger reconsultation, and ensure that patient understanding is there so that they can ask any questions they need to clarify the issue. I think if you remember nothing else this evening, the 3 strikes rule, or Jess's rule, is super important to take away. If somebody continues to present with that same or escalating symptoms, and they've done it 3 times already, do something different. Think about what else can you do. And that's where we've got non-specific pathways, whether that's through a rapid diagnostic centre or diagnostic service, may be available to you as an option. Remembering that GP gut feeling, or how I describe it to trainees as your spidey sense, that there might be something nasty underlying symptoms, is a recognised reason to refer, and has been shown to help speed up diagnosis in patients who are referred down these non-specific pathways. Okay, let me pause there for a second and see if Nick has got any feedback on that for us.
Thanks, Kate. There are many questions now flooding in, so I'm just typing my way through them. I think a couple of themes that are coming out. I think there are some people sort of talking about the balance that we have to strike as GPs around not over-referring as a consequence of this. We're talking about the difficulty in identifying people with cancer who have vague symptoms. And I think that data that you presented at the start, that people who are high referrers tend to pick up cancer earlier, is a challenge to us, isn't it? I don't think there's an easy way around that. I mean, I think obviously we do have to go back to that sort of basic approach of making sure that we are thorough, that we assess each individual patient. I think continuity can really help there. I just had a week off ill recently, and a patient I know very, very well ended up being referred to the medics on the day that I didn't see her. And she was fine. And I think if I'd seen her, she probably wouldn't have been referred. So I felt a bit bad about my day off costing the NHS, £1,000 for an acute medical assessment. But we all know people very well, don't we, in general practice? I think that can really help. So there are a lot of elements to it that we can bring through there. I think these non-specific cancer referral pathways really, really help. Some of the data that's come out from Oxford show that one of the key presenting sort of symptoms, if you like, that led to a cancer diagnosis was a gut feeling from the GP. And I think that sort of plays into it. So our clinical intuition and our experience is really, really valuable here. But what they also found from those data was that nearly 10% of people referred to those sort of scan type pathways were diagnosed with some form of cancer. And I think that shows that there are quite a high proportion of people who present outside some of the other traditional sort of clear 2-week wait referral pathways who will have cancer. And, the important thing that we're trying to get at tonight is to not ignore those or sit on those symptoms too long. But if we're seeing people repeatedly coming back with vague symptoms, thinking about escalating that or sort of trying to use some of these tools that we're talking about to follow up on people appropriately. I think there are some useful primary care data out there. So there was a cohort study published in the BJGP a couple of years ago where they tried to draw together some of these non-specific symptoms. I imagine you can all sort of tell what it's going to show without looking at it. The more vague symptoms that you have in combination, the more that they overlap with things like anemia or other blood test abnormalities, the higher the probability that you will have some more significant underlying illness that goes with that. So combination of symptoms, blood test abnormalities, they are important things to look for, but of course they don't completely rule out a cancer as well. So it's a challenge. I said at the start that I spend part of my week working in primary care, part of it working in secondary care. I can tell you right now that the challenging cases come through primary care. They're the people that I find really, really difficult. In secondary care, I often find there's much clearer, investigation pathways. People tend up getting a lot more imaging at an early stage of treatment that gives you reassurance about what you're dealing with. I think these non-specific symptoms are a real challenge in primary care. So it's not easy stuff. And, we're not telling you the right answers here. People are sharing lots of experiences, Kate, about early cancer diagnoses, people being diagnosed with cancer at an early stage at their practice. And it is really, really challenging. And of course, we've all had those cases, and they're the people that really sit with you, aren't they? Those kind of 30-year-old diagnosed with cancer out of the blue. It really, really, they all live with us a long time, I think. I'm going to go back to answering questions because I know you've got a bit more to get through, Kate. Sorry to sidetrack.
Thank you very much, Nick. No, not at all. I absolutely agree with all your sentiments there. And yes, this is not an easy, these are not easy scenarios, and we've all got tales to tell. I guess the hope with webinars like this is that we just make life perhaps a little bit easier when it comes to the next patient that you have that may be applicable. Thinking about negative results and ongoing symptoms for a second. So around 10% of colorectal cases, you might be interested to know were given a negative symptomatic FIT result before their colorectal cancer was diagnosed. I'm going to present to you a lady who had a false negative CA125. Again, patient that we had in the practice, presented with non-specific symptoms, had a CA125. CA125 came back. It was under 35, so reassured that her symptoms weren't anything too serious. Then underwent a FIT test because she's had ongoing abdominal symptoms. Again, that was negative. Reassured about that too. 6 months later, came back, and lo and behold, unfortunately, she had ovarian cancer, and by then it was stage 3. So that was the scenario that I was going to present to you, but in fact, I can see the managing negative results. So colorectal cancer cases, 10% false negative for a FIT test. So although they're very good, they're not perfect, and therefore we do need to remember to safety net. Lung cancer cases, 20% of those get given have a chest X-ray, which is reported as normal, and then subsequently they're diagnosed with lung cancer. So again, they're good to use, but they're not perfect. And even thinking about ovarian cancer for a second, if you use a threshold of 35, evidence suggests that around 20% of those are missed if we use that cutoff of 35. And it's really interesting to know that we anticipate the new NICE guideline for ovarian cancer diagnosis to be updated or to come out next month. And we think it's going to come out next month. The draft version has suggested different thresholds depending on age for diagnosing ovarian cancer. So that's something just to look out for in the medical press going forwards over the next few months, because that is certainly something that I suspect we will see change in the NICE guidance coming up. So given that all of these tests are not perfect, the question I suspect you're wondering is whether or not we should be using them at all in primary care. Why don't we just go to something that's more specific or more sensitive and a better test to use? But the thing you have to remember is all of these investigations are appropriate to use because within a primary care population where the prevalence of disease is quite low, all of these tests are actually pretty good because their negative predictive value, if they're normal, is very high. It sits at around 99%. So you can be pretty certain that somebody doesn't have a disease, but you do need to safety net them to come back because they're not perfect tests and false negatives do occur. So the take-home message there is really to keep patients under review until symptoms are explained or resolved. If they do come back, make sure you revisit that history and examination. If patients have been managed remotely, and of course lots of patients do get managed remotely these days, make sure they've had that face-to-face appointment. It's always worth checking a family history for other cancers in the family, because that might increase your level of suspicion. And I guess I'm alluding here to the possibility of Lynch syndrome, where you can have multiple cancers over different generations that, unless you ask the question, you might not be made aware of by patients, because patients might not know to tell you. So checking a family history, of course, get patients to come back. Share some of that uncertainty with patients. So I try not to be too over reassuring, and I do try and share the uncertainty with patients so that they do come back and see us if things do not get better. And of course, remembering the 3 strikes rule, onward referral, even advice and guidance these days is a good way of getting a second opinion from specialists if you're just not sure what might be going on. So our last patient this evening, before we stop, is just very briefly to show you some of these e-safety netting tools you might not be aware of. Here's Mike. So Mike is 72. He's had non-specific bowel symptoms for a few months. He's had intermittent lower abdominal discomfort, no change in his bowel habit, no weight loss, no obvious red flags. And you've examined him, you've done your sort of simple blood tests, they're all normal. So diagnosis here is unclear. Clinical suspicion remains. So I'm sure most of us these days would now decide to do a symptomatic Q-fit just to make sure that that is normal. So you send Mike off with instructions on how to do that, and please bring it back to the practice, but it doesn't come back. And then 2 months later, he does come back, but this time he's got change in bowel habit and his discomfort's getting worse. And then bowel cancer is diagnosed. So again, here is one of these scenarios where perhaps that diagnosis could have been made a couple of months sooner. So just thinking a little bit about health inequalities, these are the groups where we just need to be sort of super careful that people don't slip through the net. It's trying to avoid that from happening. So men, those are sort of who are of a younger age, and those from ethnic minority groups or more deprived areas, they all are less likely to engage and may experience poorer health outcomes as a result. So it's these patients really where we just want to be even more active or targeted with our safety netting to ensure they don't slip through the route. So for patients like Mike, there are lots of resources out there to encourage people to complete a fit test. And firstly, it's just, ask the question, are they reluctant to do it? And if so, why? Because perhaps it's just something that you can ally with a little bit more discussion. The 2 main barriers to completing a fit test is worry or fear about what that test may find, or perhaps embarrassment about how to do the test. So, really, open discussion about how to collect a poo sample is super important. And there's a lovely CRUK leaflet, which you'll find in the resources tab, which is a great descriptor on how to complete your fit test. And even signposting patients to read that might well improve your engagement. There's also some useful other things which have already been set up for immediate use. So there is an Accurix. If you're users of Accurix, then there is a lovely pre-populated text message which you can set up as you give patients their fit kit. And if you don't know about it, you'll find it by searching fit sample reminder. And this has been done in partnership with NHS EI. So the first text that goes to patients is the one that goes on the day that you give them their fit test, which just reminds them how important it is for them to complete and bring back their sample. But what is really convenient about this Accurix is it schedules a second text message to go 3 or 4 days later. And that is have you remembered to return your fit sample? If not, please do so as soon as possible. And that is just a really nice sort of memory jogger for patients that might have gone home, popped it on the side and not brought it back to the practice. The other safety netting tool, which we use all the time in our practice, is the fit template. And this is super helpful because it essentially tells you what to do in terms of the indications for doing a fit. So it's nice to be able to read code that by ticking a box. But then the actions down in the blue box at the bottom, if you do provide patients with a fit kit, you can read code that has been provided. And that is the recode that we use to do a monthly audit on our patients so that we pick up anybody who hasn't returned the kit. And of course, there is within that template, there is the code to click that the fit kit has been returned. So just two really helpful tools, which I thought, if you haven't seen them before, you might find beneficial to introduce to your practice. So there's Mamta, our poor lady with ovarian cancer. Remember the risk of false negatives. Keep those symptomatic patients under review until a diagnosis is reached or symptoms resolve. Continuity of care here, of course, is really helpful. I mean, Nick just talked about continuity with his patients. Of course, in an ideal world, we would all see the same patients until their symptoms have resolved. Unfortunately, in the primary care world that we work in currently, that is not always possible. But of course, if that's the case, then it's all about the documentation and clear communication. Don't forget that 3 strikes rule and seeking specialist advice if those initial investigations are normal, but you are still concerned. And of course, we've already talked about the non-specific pathways that you may well have available. And then for those who are less likely to engage in investigations, just think about that targeted safety netting advice and how you can remove barriers where possible. And I've just given you a couple of examples looking at fit kits and how you can bring those back for patients. These are some of the resources which I've already alluded to that you'll find in the resources tab. How to complete your symptomatic fit in a variety of languages. The e-safety netting tools webpage from Cancer Research has got all the different systems in there and what you might already have available if you're not aware. There's loads of different information on Cancer Research, so it's well worth having a look at that. With 15 seconds to go, I don't think we've got time to go back to Nick, but I can see he is still very busy answering questions. So thank you so much for all the questions that you have put forward. I'm sorry if we haven't managed to get through all of them this evening because it's been a fairly busy old webinar. You will get a certificate available for this. Just click on the certificate in the menu bar, and we would be very grateful if you could complete some feedback because that helps us to refine and improve these clinics as we go along. I guess my last poll question is, on a scale of 1 to 10, how likely are you to recommend NB to a friend or a colleague? Bring in your answer for that. That would be super helpful. That just helps us to sort of gauge the mood of the nation, so to speak, to give us an idea on how well we're doing. Beyond that, it's 9 o'clock on the nose. I would like to say thank you so much. We are still rammed full with delegates, so it's been great to have so much chat going on. I am pretty sure Nick has got sore fingers now. I hope that's been helpful. I hope that's given you something to think about when you go back to work tomorrow. Have a fantastic rest of the week, and Nick and I hope to see you again on an NB Medical webinar soon. Bye for now.